Hello and good morning. Welcome to the second webinar from our Cardiovascular Issues in Primary Care series titled Platelets Be Gone, Navigating the Latest in Antiplatelet Therapies, hosted by the Office of Lifelong Learning and the Physician Learning Program at the University of Alberta. My name is Nandini Desai, and I'm a pharmacist and a clinical liaison with the Office of Lifelong Learning and the Physician Learning Program. The Physician Learning Program and the Office of Lifelong Learning are committed to providing reliable updates and resources for clinicians, healthcare workers, and everyone committed to providing the best clinical care for patients. So I'd like to begin with the land acknowledgement. The University of Alberta, its buildings, labs, and research stations are primarily located on the territory of the Cree, Blackfoot, Métis, Stoney, Dene, Iroquois, and Ojibwe lands that are now known as part of Treaties 6, 7, and 8 and homeland of the Métis. The University of Alberta respects the sovereignty, lands, histories, languages, knowledge systems, and cultures of all First Nation, Métis, and Inuit nations. So I'd like to start with some housekeeping information. So please use the chat feature if you have a question about any technical difficulties or regarding L3 programs and services. If you have a question for the speaker, please use the Q&A feature of the webinar. Please review what has already been asked and feel free to upvote those questions you would like answered. We cannot guarantee that the panelists will be able to answer all of your questions today, but we will do our best. A recording of the webinar will be sent via email to all those people who have registered. So participants can claim CME credits and complete a personal development activity using my L3 Plan tool. And you can find the information and the QR code for more information on that here on this slide. Just know that this activity has not been formally reviewed by the CFPC or the Royal College. However, it is eligible for non-certified credits. And Main Pro Plus participants may also earn additional certified credits by completing a linking learning practice exercise. And now it is my pleasure to welcome you all and to introduce our speaker for today, Dr. Kevin Bainey. Dr. Bainey is an interventional cardiologist, a graduate of the University of Alberta's Medical School. Dr. Bainey pursued an interventional cardiology fellowship at Harvard University, Boston, and subsequently became a clinical scholar in interventional cardiology at McMaster University, Hamilton. He was the recipient of numerous awards during his undergraduate and residency medical education. He has also completed a Master's of Science degree in Health Research Methodology at McMaster. And in 2011, he was recruited to the University of Alberta's Division of Cardiology and now works at the Mazankowski Alberta Health Institute. Dr. Bainey is the director of the Adult Cardiac Catheterization and Interventional Cardiology Program at the Mazankowski Alberta Health Institute and the University of Alberta Director for the Royal College of Physicians and Surgeons of Canada Area of Focused Competence Interventional Cardiology Fellowship Training Program. He also holds the ECG Core Lab Director position at the Canadian Virtual Coordinating Centre for Global Collaborative Cardiovascular Research, called VIGOR Research Centre at the University of Alberta. He's active in national leadership roles, and those include a co-director for the Canadian Association of Interventional Cardiology Fellows Device Course. He is also the vice president of this committee, and he is the co-chair of the 2023 Canadian Cardiovascular Society Antiplatelet Guideline Committee, We are excited to hear his presentation today. He leads a number of research trials in the for cardiovascular conditions. Thank you all and welcome. And please take it away, Dr. Bainey.
Great, thanks for the introduction. So we'll hopefully be able to finish within 45 minutes. What we're going to review really is the latest edition of the Antiplatelet Guidelines. So the title is here, Platelets Be Gone, Navigating the Latest in Antiplatelet Therapy. Okay, good. So just to highlight, this is very recent. This was published really at the beginning of 2024 with regards to the update of the antiplatelet guidelines from the Canadian Cardiovascular Society. I had the privilege of being the co-chair and first author of this document. But what I also wanted to highlight is that there are many others that are highlighted on this slide that are from the University of Alberta. So University of Alberta certainly had a big part in the guideline production. So there are really 7 questions that we felt were pertinent to the modern day clinician with regards to how to navigate or handle antiplatelet therapy. This is always a moving target. We've advanced quite tremendously over the past 20 years with the use of antiplatelet therapy. And these were contemporary questions that I felt that clinicians needed to be updated to improve upon clinical care. So the first, I think, is very relevant to this audience and arguably the most relevant topic to the audience is the use of aspirin therapy for primary prevention in patients who have established atherosclerotic cardiovascular disease. So, when I trained here at the University of Alberta as a medical student, we were told that everyone had to be on aspirin for primary prevention, given that, over the age of 50 or had some risk factors, it was just an automatic that they were on aspirin for primary prevention. And I always remember the saying that an aspirin a day keeps the doctor away. However, this has been questioned most recently with 3 very large randomized trials, all published in the New England Journal of Medicine, which questioned whether or not the routine use of aspirin for primary prevention is needed. It goes on to question whether or not we should be using it in diabetes, males versus females. And as a result, there has been a dichotomy of different recommendations across the world with regards to the use of aspirin for primary prevention. So the Europeans are quite adamant that we do not use aspirin for primary prevention. The Americans have said, yeah, no, but we think that anyone over the age of 65 and has some risk factors, they should be on aspirin for primary prevention with no good evidence to support that claim. And so in Canada, we felt that this was a very important topic to really dive into the evidence and try and provide clinicians with the answer. And I do want to take a step back and say these guidelines are the most evidence-based guidelines that have been published from the Canadian Cardiovascular Society. I was adamant that every question have a robust systematic review and meta-analysis done, and many of those have been published separately in different journals. So this, rest assured, is the most contemporary evidence-based recommendation in the world, and we vary across the world as well, which is quite nice, and again, I think is pertinent to Canadians. So our recommendation is that we recommend against the routine use of aspirin for primary prevention, regardless of sex, age, or diabetes in patients without atherosclerotic cardiovascular disease. Strong recommendation, high quality of evidence. So I highlight that routinely, we should not be prescribing aspirin for primary prevention. And it doesn't matter, sex, age, or diabetic status. However, we followed this statement with what we call a best practice statement. And I will tell you why we did this. So that as a primary care physician, you do have the ability, supported by the guidelines, to recommend aspirin for primary prevention in patients who are at high ASCVD risk, whichever risk score calculator you want to use, but has to be of low bleeding risk. And this needs to be done in a patient-centered, informed, shared decision-making process. In other words, we talk to our patients and say, these are the risks, these are the benefits, and you as a clinician and the patient can decide if you want to be on aspirin for primary prevention. And the reason why I was adamant that this recommendation be added to our guideline document is the fact that there is no question in my mind that aspirin reduces your risk of death, MI, and the relative risk reduction is 10%. It is quite clear these are all RCTs. The confidence intervals are super tight around the point estimate. This, I am confident to say to patients, there's a 10% relative risk reduction of taking aspirin for primary prevention in terms of reducing your risk of death or non-fatal myocardial infarction. This is driven mainly by the reduction in having a heart attack in the future, and we published this separately in a document in CJC Open. And that's, again, just to reiterate that there is benefit in terms of efficacy for being on aspirin. However, it is outweighed by this small, and I want to reinforce this, very small risk of major bleeding, and the bleeding that we worry about is intracranial hemorrhage. It's a very, very low risk. You need to treat 1,000 patients before you see one risk of intracranial hemorrhage. So that's where the risk versus benefit comes into play. And in this document, every question that we answer has a slide attached to it. So really, it's just focusing on the slides, and this slide highlights that it's a shared decision-making model with the patient and the clinician in terms of presenting this slide and saying, yes, we're going to reduce your risk of a heart attack, but there's a risk of bleeding, albeit the risk of intracranial hemorrhage is exceedingly low. And in a patient, say, who is, in their 50s, 60s, who has huge risk factors and no bleeding risks, there's no reason to think that that person shouldn't be on aspirin for primary prevention. And so having that discussion with the patient in this document supports the use of aspirin in those selected patients. We also, in this document, and feel free to download this and go through the supplementary index, there's actually a decision aid questionnaire that we have created that can walk you through with your patient. And at the end of that questionnaire, it's yes, no for being on aspirin for primary prevention. So we've given you all the tools to make those decisions. The second question that we wanted to answer was the use of dual antiplatelet therapy following PCI, following a stent in patients who are at high bleeding risk. Now, the magic duration that we all know about is the 1 year after you've had a heart attack or 1 year after you've had a stent placed, that you should be on 1 year of dual antiplatelet therapy. And that still holds. However, we can extend or shorten that duration depending on the patient's clinical presentation. And now what we are recognizing is that bleeding is a lot more of a big deal than we ever thought before, because bleeding increases your risk of a prothrombotic environment. Bleeding is attached to mortality. Bleeding increases your risk of a heart attack. Bleeding oftentimes the patients decide to stop their therapies because they're having bleeding issues. So bleeding is bad for you. However, we never had a very good way of defining what a high bleeding risk patient is. Well, this guideline document and this slide allows you to say, okay, this patient is at high bleeding risk, and this is evidence-based, and you need to meet one major criteria or two minor criteria to say this is a high bleeding risk patient. So the major criteria are quite obvious. The minor criteria, if you're over the age of 75 and your hemoglobin is 110 or less, you are a high bleeding risk patient. Okay, so the threshold to define this is fairly low because we know these patients bleed. And so once we identify a high bleeding risk patient, can we shorten the dual antiplatelet therapy to mitigate their risk of a bleeding event? And the answer is yes, because the stents that we use now are very, very safe. And we can get away with a very short duration of dual antiplatelet therapy. And so in our recommendations, again, which is evidence-based on RCTs, is that you can get away with as short as 1 to 3 months of dual antiplatelet therapy in a patient, irrespective if it's ACS or elective PCI. 1 to 3 months is a safe range to shorten your dual antiplatelet therapy to single antiplatelet therapy. And of course, we would advocate or promote this in a high bleeding risk patient. And so the figure that we have that navigates the clinician, whether it be a family physician, an internist, a cardiologist, is looking at this figure. This will help navigate what you do with the antiplatelets. So if you've had a heart attack and you're on that dual antiplatelet therapy for your heart attack, but you're a high bleeding risk patient, well, you can de-escalate to single antiplatelet therapy anywhere from 1 to 3 months. And then we have another strategy that I will present in the next question, where you can also reduce the potency of your dual antiplatelet therapy. The standard is 1 year, and the standard is more potent dual antiplatelet therapy with what we use here, ticagrelor and aspirin versus clopidogrel and aspirin. And then you do have an option of extending dual antiplatelet therapy. You'll see that many of us will recommend this for a complex PCI in an ACS patient who is in their 40s and has no bleeding issues whatsoever. We may say going out to 3 years. And in the elective PCI patients, so these are non-heart attack patients that are having chest pain in the community, come for their angiogram, have a stent placed, we now say the standard of dual antiplatelet therapy for those patients is 6 months. It's not a year, it's 6 months. And that you can also de-escalate in this arena in a high bleeding risk patient by dropping to single antiplatelet therapy anywhere from 1 to 3 months. So this is just more so meant for the cardiologist and the interventional cardiologist, in that you may come across a situation where you've done more complicated PCI procedure requiring a longer duration of dual antiplatelet therapy. We now provide evidence-based what we define now as complex PCI. And so when you have complex PCI, you would think about, okay, maybe going a little bit longer with your dual antiplatelet therapy. If it's an HB, high bleeding risk patient, you may not want to go to 1 month of dual antiplatelet therapy. You might want to just extend to 3 months because of the complex PCI that you've done. So the next question to answer is dual antiplatelet therapy is going to be around for a long time, but we have different choices for dual antiplatelet therapy. Our standard has always been aspirin and clopidogrel. However, what you've seen now is that our standard really is aspirin and ticagrelor, but we have another antiplatelet option, which is aspirin and prasugrel. And so the question is, of those two more potent agents, ticagrelor or prasugrel, which one is better? And once you're on more potent dual antiplatelet therapy, when is it safe to drop to less potent dual antiplatelet therapy? And so we will walk you through that. So this is a guy who's 71 who has been admitted with a non-ST elevation MI, has an angiogram and had PCI done, and is discharged on day 3. He is discharged on aspirin and ticagrelor. And the question is, what is the best potent and dual antiplatelet strategy to use? Is it aspirin and ticagrelor, which we use most commonly in Alberta, or the other option is aspirin and prasugrel? And what we did is we looked through the literature, and in fact, aspirin and prasugrel has a very good profile and is just as good as using aspirin and ticagrelor. So we've said no preference. You can choose either or. And where this becomes important is that In a patient who has the shortness of breath from ticagrelor, instead of switching to aspirin and clopidogrel, you can give the patient the more potent benefits and switch over to aspirin and prasugrel. And prasugrel is available for our patients in the community. It is generic, and we really should be using more of this therapy. And so this is the reason why. This is just a meta-analysis showing that there's no difference in death when using aspirin and ticagrelor or aspirin and prasugrel. So they're both potent strategies are reasonable to use. And then, this patient then comes back at 30 days and for whatever reason is not happy with his more potent dual antiplatelet therapy. Maybe it's due to costs or maybe it's due to nuisance bleeding. And he wants to know, say, doc, I don't want to stay on this stuff for a year. Can we go to something a little bit less potent? And the answer is at 30 days, you can. You can drop to less potent dual antiplatelet therapy, which is aspirin and clopidogrel. And that is safe to do after a month of, let's say, aspirin and ticagrelor. And you don't need to bolus them. So if they're on their 90 BID and of ticagrelor and aspirin, after a month, you can just switch over to aspirin and clopidogrel 75 milligrams daily. You don't need to bolus them with clopidogrel. So here we've said again, we suggest the option of de-escalating potent DAP by switching to clopidogrel-based DAP in the appropriate patients, and you can do that as soon as 1 month after using more potent DAP therapy. And this again is just highlighted in the figure that are standard for an ACS patient should be more potent dual antiplatelet therapy with aspirin and ticagrelor or aspirin and prasugrel. And that is preferred over aspirin and clopidogrel. But at a month's time, you do have the option of de-escalating to an aspirin and clopidogrel strategy, less potent DAPT due to whatever reasons from a clinical standpoint. So the next topic is we see a lot of patients, and you will see a lot of patients that say come in with an ACS and have an angiogram done, and the disease is really complicated, lots of diffuse disease, and is not a candidate for revascularization, not a candidate for PCI, not a candidate for bypass surgery. What do you do in those patients in terms of treatment of their antiplatelet story? And so, this is just a question. Do you think about aspirin and ticagrelor for those patients, aspirin prasugrel, or aspirin and clopidogrel? What we've said, again, based on evidence, is that we recommend, if you're thinking about aspirin and clopidogrel over aspirin and prasugrel, there has been a randomized trial that has addressed this and shows that actually aspirin and clopidogrel is safer than aspirin and prasugrel for medically managed coronary disease. So in our figure, we've said, don't even think about prasugrel in this arena if you're thinking about clopidogrel versus prasugrel. If you're thinking about clopidogrel versus ticagrelor, we've made the recommendations that, probably think about the ticagrelor aspirin over aspirin and clopidogrel, with a weak recommendation because there's really not a good RCT. It's a subgroup analysis that was done, but this is the figure that gives that recommendation. So we say that these should only be type 1 MIs, so the MIs that come in with true plaque rupture that cannot be revascularized. If you're thinking about clopidogrel or prasugrel, choose clopidogrel. If you're thinking of clopidogrel versus ticagrelor, choose ticagrelor. And that is based on the data that we have collected, which is the most contemporary data that is out there. What about, this is relevant to the audience in terms of family physicians who, let's say, have identified a patient that they have seen that you worked up for chest pain in Alberta. Family physicians can even go ahead and order perfusion imaging with a MIBI scan, and it comes back positive, and you're very confident that this patient has a significant coronary lesion that is, causing their angina. We see a lot of these referrals coming in, and the patients are placed on dual antiplatelet therapy. And the question is, do you really need to preload your patients with dual antiplatelet therapy, or can you just wait on single antiplatelet therapy till they get to the cath lab to figure it out? So that's with the heart attack patients, which I think is less relevant to the audience. But for patients that come into the hospital with a heart attack, we are preloading everyone routinely. But when we looked at the data, it's actually not necessary to preload everyone. If you can get them to the cath lab within 24 hours, we're saying you don't preload. You wait to define their anatomy. And if they need urgent bypass surgery, they can go for that in the next day or two without having to hold your dual antiplatelet therapy. So this allows them to get their treatment quickly. However, if you're going to wait more than 24 hours to get to the cath lab, we do say that we have to preload our patients with non-ST elevation MIs because of that ischemic risk of while waiting for an angiogram. And in the STEMI population, it's a no-brainer to preload. But this is what I think is relevant to the audience, is that in patients who are elective, so in the community, walking around with chest pain, and the reality is these patients can wait up to 3 months before they get an angiogram in our Canadian system. So do not put them on aspirin and clopidogrel, or just keep them on aspirin only, because you're just going to increase their bleeding risk. There's no efficacy in doing that. And we deal with it in the cath lab. So when they come to the cath lab, we give them their bolus of clopidogrel, and we are able to do their PCI. And so, yeah, don't put them on aspirin and clopidogrel while referring them for an angiogram in the community, because it just increases their bleeding risk, particularly when they have to wait so long to get an angiogram in Canada. This is just a figure to highlight that, what I've told you, and specifically for this audience here, we recommend routine pretreatment with P2Y12 inhibitor is not recommended in elective PCI or patients with stable ischemic heart disease. Now, again, moving on to the cabbage story. Again, maybe some of you, do inpatient work, so this may be relevant to some of you. But those patients that are admitted to hospital and now have to undergo bypass surgery, what do you do in this context with antiplatelets? They're on their dual antiplatelets. What do you do before? And then, which is going to be relevant to the audience, is what do you do afterwards, after they leave the hospital with their bypass surgery? So 74-year-old lady who has a history of diabetes, hypertension, and hyperlipidemia, and presents with an NSTEMI and is on ticagrelor or an aspirin, and has an angiogram done with very bad disease, and the heart team is gathered, and the recommendation is urgent surgery. What do we do? Because this patient's already on aspirin and ticagrelor, and the surgeons are apprehensive to take them to the operating room the next day because of their bleeding risk. How long do we hold the ticagrelor before they go to the operating room? And what was done as a standard was 5 to 7 days. However, when we looked at this and the way ticagrelor works, is that it is very safe to go to the operating room anywhere from 2 to 3 days after holding ticagrelor, as opposed to waiting that 5 to 7 days, because ticagrelor is out of your system in 2 to 3 days. And where this is relevant to the audience is that I know there are many situations that patients are on dual antiplatelet therapy and need some sort of procedure to be done. You don't have to hold the ticagrelor for 5 to 7 days. You can hold anywhere from 2 to 3 days, and that is very safe. It is out of your system. Of course, continue with the aspirin, and then they can have whatever procedure that they need at that point in time. This is just data, Canadian data, actually, to highlight that it is safe to stop 2 to 3 days for ticagrelor versus waiting the 5 to 7 days. There's no bleeding differential in bleeding risk when they go to the operating room. The clopidogrel story is a little bit harder to sort out as there's not much very good randomized data that is out there. But essentially, we looked at a bunch of studies, and for clopidogrel, because it stays onto the platelet. Ticagrelor is a reversible P2Y12 inhibitor, meaning that when you stop it, it comes off of the platelet in 2 to 3 days. But with clopidogrel, it's irreversible. It stays on the platelet until the platelet dies, and the platelet dies in 5 to 7 days. So with clopidogrel, we really do say that you got to stop it 5 to 7 days before considering any operation. And here it's CABG surgery. So just to remember, it's safe to stop ticagrelor 2 to 3 days. With clopidogrel, you should stop it 5 to 7 days before their surgical procedure, and that's our recommendation. This is the clopidogrel story for our recommendations as well. And then there's just a nice figure to highlight that when it's safe to stop this stuff before bypass surgery. And then this is what I think is really important, and this is going to change how when patients come out of the operating room are discharged from the hospital and then see their family physician in a few weeks after their bypass surgery operation. And so the question is, what do you do after bypass surgery with their antiplatelets? Do you restart them? And does it matter if it's in the setting of a heart attack, or is it a patient that has had elective CABG surgery? And the big question was, does dual antiplatelet therapy post CABG surgery improve the chances of your bypass graft staying open? And the answer, based on review of the literature and of all the RCTs, the answer is yes. Dual antiplatelet therapy increases your chances of your bypass graft staying open. And it doesn't matter if it's in the setting of an ACS or elective PC or elective CABG. Once they leave the hospital, they should be on dual antiplatelet therapy to improve their graft patency. And this is out to 1 year. Why? Because within that 1 year, if the graft is going to go down, it goes down within that first year, because it's usually related to some sort of procedural technical issue. And so if it's, say, a tight anastomosis, well, if you're on dual antiplatelet therapy, it's more likely going to stay open in that during that first year. And so we strongly do recommend this, and this will take a while for surgery to catch on, but you will see more of these cases being discharged on dual antiplatelet therapy. However, many will not. And so this is where the family physician, when you see a patient post-bypass surgery and is not on dual antiplatelet therapy because they've not followed the guidelines, that's your opportunity to start them on dual antiplatelet therapy. Because our guidelines do recommend that. And of course, legally are protected because of these guideline recommendations as well. So think about those patients that you see following bypass surgery. And, there may be a reason that they shouldn't be on it, but otherwise the default is that they should be on dual antiplatelet therapy following their bypass surgery. And that's highlighted in this figure as well. So the last topic, which I think is also very relevant to the community physician, is this whole concept of needing dual antiplatelet therapy for your stent, but you may have another reason for requiring oral anticoagulation with a DOAC or warfarin due to, say, atrial fibrillation. So now you've got a patient who needs oral anticoagulation for AFib, but we need to protect the stent with dual antiplatelet therapy. And this is what we call triple therapy, being on dual antiplatelet therapy and oral anticoagulation. And for the longest time, we were doing that until we realized this is not safe. Patients are bleeding, and bleeding is associated with mortality, and it is not safe. And so this story evolved over many years to essentially tell us now that if you have an opportunity to shorten or discontinue triple therapy, you need to, because that is going to reduce the risk of your patients bleeding, but it doesn't harm the risk of atrial fibrillation, or it doesn't harm the risk of your stent. And I'll tell you the algorithm that we use. So 79-year-old lady who presents with atrial fibrillation, has permanent atrial fibrillation on an oral anticoagulation with apixaban, presents with a ST elevation MI, receives 2 drug-eluting stents to the LAD, and is discharged on day 3. And the question here is, what do you discharge that patient on? And the answer is we go as quick as possible to what we call a dual pathway approach. Dual pathway means 1 antiplatelet, 1 oral anticoagulant. So when they're in the hospital, we have them on their aspirin. Plavix is your only choice, or clopidogrel is your only choice for your P2Y12 inhibitor, and then oral anticoagulation. So this patient in the hospital will be on aspirin, Plavix, and apixaban. But when they leave the hospital, the aspirin is dropped, and the patient comes out in the community on clopidogrel and oral anticoagulation. That's what we call a dual pathway strategy. And we know from all of the meta-analyses that we publish separately that it's safe. It's safe for the stent to just be on oral anticoagulation and clopidogrel therapy. You do not need to be on aspirin. And it's, of course, safe for atrial fibrillation because you're covered with oral anticoagulation. So that's what a recommendation says, that we strongly recommend going to a dual pathway approach as quick as possible. But we do recognize that there's going to be certain situations, and an example would be very complicated PCI that we do that we feel probably needs to have that aspirin on for a little bit. While we say that that little bit is only 30 days. So you have a maximum of 30 days to be on triple therapy, aspirin, clopidogrel, and apixaban, let's say. But after 30 days, there's no need to be on aspirin. So the message here is switch to a dual pathway approach as quick as possible. And most commonly, this is being done before they leave the hospital. However, in a very small patient population, they may come out with aspirin as well. However, there's no reason to be on it after 30 days. So that really needs to be clear to the community. And then the other question is, now that you're done, let's say at a year's time on a dual pathway approach or whatever you have, antiplatelets and oral anticoagulant, now you're done treating the stent. And the patient obviously has to live with atrial fibrillation. They have coronary disease. They have had a prior stent. Do you still need to be on an antiplatelet and oral anticoagulation once they're stable? And the answer is no. And we see this very frequently. There's no need to be on both an antiplatelet and an oral anticoagulant once they're stable from their heart attack, once they're stable from their stent. You just need to be on oral anticoagulation alone. So in this patient, let's say after a year's time, who's on clopidogrel and apixaban, at a year's time, you're done treating the stent and the heart attack. So then just drop the Plavix and the patient's on oral anticoagulation alone for life. That should be really clear. And that is very important for the community physician to understand. And this is the figure that just goes through what I've said in terms of those recommendations, essentially stating that in a patient that requires oral anticoagulation and antiplatelet therapy, shift to a dual pathway approach very quickly. And then once you're done treating the stent or the heart attack, oral anticoagulation alone is sufficient. So those were the 7 questions that are highlighted in this document. Again, it's free to download, and really the figures are what speak to all of the questions. They're really easy to follow, and encourage you to just download the figures to really remind you of the salient features that I've presented today. And again, just want to acknowledge that there was a lot of University of Alberta participation in putting this document, and of course should be proud that the University of Alberta really was instrumental in putting this document together for clinicians in Canada. So thank you, and I'm open to answering any questions.
Well, thank you so much, Dr. Bainey. That was excellent review of the new guidelines. It looks like we have one question, and the question is just referring to your ASA being used in primary prevention. Should all patients with reports, and he's given an example of MPI that mention the presence of subclinical atherosclerosis, be on ASA?
Yeah, the short answer to that question is yes, because you know, the MPI is pretty accurate in terms of identifying ischemic risk, and let's say there are many patients that are out there that are, you know, low risk MPI scans and may just be managed medically, and then of course aspirin would be essential, but otherwise, yes, in that patient where you're worried about having subclinical atherosclerosis, aspirin is very important to start until they get their cath. And maybe it'll be a false negative, and then you can stop the aspirin, but or sorry, a false positive, and then you can stop the aspirin. But you know, further pushing this question is, how do you define primary versus secondary prevention? And in the document, we've stated that, let's say if a patient really gets a CT scan, for instance, and you know, for whatever reason, and now on the CT chest, they're often reporting calcification in the coronaries, or they get a coronary angiogram and CCTA, and it reports subclinical atherosclerosis. We are clear in the document that that pushes you on the secondary prevention spectrum, and antiplatelets, i.e. aspirin, is important to be on. That is not primary prevention, that is secondary prevention. And then you go down the pathway of, you know, statins and all of that stuff as well.
Thank you. I actually have a question that I've come across. So if you have patients who have uncontrolled hypertension, what are your recommendations regarding using aspirin and these agents?
Yeah, I think that if you've got uncontrolled hypertension, and so again, for primary prevention, this patient's not had any events, I would say that routinely, again in the document, we recommend against aspirin. However, if that hypertensive patient has, you know, lipids, LDL of 5, and you know, is having atypical chest pain, or you know, has a strong family history, i.e. your Framingham risk score is high, then it's a discussion with the patient based on that first figure about the risks and benefits of aspirin for primary prevention. And if that hypertensive patient is of low bleeding risk and high Framingham risk score, whatever score you want to use, discussion with the patient, and if the patient agrees, aspirin for primary prevention.
Thank you. So I'm just wondering, are there any other questions from the audience for the speaker today? Doesn't look like it. So thank you so much, Dr. Bainey, taking the time. That was actually a very practical presentation that something we can use in our practices. I wanted to just let everybody know, if you can take a couple of minutes, this survey, feedback survey, to help us improve our programs. It should only take you 2 or 3 minutes, you know, to fill out, and it gives us a real idea of how to improve our program. So please do fill out the surveys. And Dr. Bainey is going to speak again on May 27th. And at that time, he's going to speak on the cardiovascular health in South Asian communities and some insights for primary care. So it's you know, a session that I'm really excited about and really looking forward to it. So hopefully you can all make it on that day, and please use the link that's being provided here. And I think we just have a comment from William Patton, Dr. Bainey, just to say thank you for the excellent presentation.
Great. No, happy to do this.
Okay. So thank you all.
Great, thank you.